Chapter 21, Cognitive Impairment. So cognitive impairment describes disturbances in cognitive functioning. So this can be disturbances in memory, orientation, concentration. Other disturbances of cognition affect intelligence, judgment, learning abilities, perception, problem solving, psychomotor abilities, reaction time, and social intactness. So our cognition is a lot of everything, really, if you think about that. And remember, even last term that we learned about how cognition is associated with our spiritual and internal and emotional. I mean, it's associated with everything. Just think of some of these things we just read here with judgment, learning abilities, perception, that can all affect the entire person. So cognitive impairment is going to be a really difficult thing to deal with for a person going through it. So the 3 Ds of cognitive impairment, and again, we learned about all 3 of these last term, so some of this will be refresher, are dementia, delirium, depression. Remember, like with dementia, that is something that it's not going to get better. It continues to get worse. Delirium can be reversed. In depression, we learned about depression quite a bit, and you guys know what that is. So all 3 of these frequently affect an older adult. However, they are not the normal consequence of aging, but the impairments do increase with age. So not a direct effect of getting older. However, it is something that is increased to happen with older age. So the pathological progression of the 3 Ds requires urgent assessment and intervention. And if you guys remember, there was a lot of, we did a lot of talking about assessment and intervention, especially with delirium, because that's something that we can reverse if we catch it early. So comprehensive workup, you can read through these here. These slides are available for you as well. I don't really need to go through all of this stuff on the slide, but make sure that you do. Considerations in cognitive assessment. So we want to look at poor performance on test and of memory can cause anxiety. I'm sorry, let me reread that. Poor performance on test of memory cause anxiety. So a patient that is taking some kind of test, for instance, let's say the mini cog that we just learned about, we're giving that, or we're giving the clock test, it's going to cause anxiety for somebody who's aware that they have some type of cognition issue going on. So we want to try to help as best we can to manage that anxiety before we, perform the test. Assessments need to be performed with hearing aids and glasses. If the patient has both of those, we want to make sure that they have all the tools necessary for success, especially if they have visual or hearing impairments. Environment should be free of distractions when assessment is performed. And assessment is best completed immediately upon awakening. Okay, so we're going to go next into delirium. Delirium, the onset may be acute or subacute. Symptoms develop over a short time, so hours to days. Symptoms can fluctuate over the course of the day and are worse in the evening. And symptoms may include disturbances in consciousness and attention, memory deficits, perpetual disturbances accompanied by delusional or paranoid thoughts and behaviors. So remember, if you recall, we talked about delirium and how it can be caused by medications. We can also see it with like an ICU psychosis. Again, we want to find what the underlying cause is and try to fix it. And it can be caused a loss in consciousness. So I actually had the current mental health students asked me the other day about delirium and why dementia doesn't cause a loss in consciousness. They couldn't quite understand. Remember, consciousness is more so like my alertness. And if I've lost my consciousness, I may not know where I'm at. I may not know what's going on. It's sort of like similar to not quite passing out, but sort of like getting ready to pass out, maybe staring off. Again, this is stuff that can be reversed versus with dementia. There's not a loss in consciousness because a person can be awake. They just have lost the memory. So there is a difference in that. Causes of delirium. So we have a lot of different things that can cause it. You'll see medications is in there. Restraints, procedures, severe illness, sensory impairment, cognitive impairment. So there's a lot of different things that can cause the delirium. A highly vulnerable older individual requires few precipitating factors to develop it. So what that's saying is that it can happen pretty easily and quickly for the older adult that is vulnerable already and is reversible. Consequently, an accurate diagnosis is needed, and that was also the problem. If you recall that it's one of the leading things that get missed. So we have to make sure we're paying careful attention and knowing the baseline of our patient when they first came in versus things that change. So consequences of delirium is a high priority nursing challenge for all nurses who care for older adults. Is a stressor for nurses and families, and is associated with lasting cognitive impairment and psychiatric problems that may persist after discharge. Again, that comes right back to identifying it early and reversing the cause, because if we don't, there can be lasting impairments from it. The lack of recognition, so we have inadequate education about delirium, lack of formal assessment methods, the view that delirium is not essential to the client's well-being, failure to recognize, and failure to initiate timely interventions. Those last two are, I would say, are the most important. There's this failure to recognize the delirium, and then there's a failure to initiate timely interventions to change it. So implications for the geri nurse. So instruments that we can use for assessment, we've already actually covered some of this. The mini mental state examination, but as you guys know, the mini cog we are leaning more towards now versus the mini mental state exam, just because of the time that it takes. However, that can be one. There's also confusion assessment method, and then your confusion scale. I won't be going specifically into those for you guys. You can read up on those in the book, but that won't be part of the testing. You want to know that we have these instruments available to us to test. Determine the client's mental status. Intervention begins with prevention, so we always go back to that. We definitely want to try to prevent anything or any kind of cognition deficit if we can. Sedatives or analgesics may reduce the incidence or duration of the delirium. So that may be a little opposite of what you may have thought, but you know, if we do that and don't allow the patient to really get this major confusion going on with that, and just kind of rest their body, we can actually help with the incidence of that. So dementia is, the onset is gradual and slow. The pattern of decline is steady without alterations in consciousness. So I just said that a second ago. Make sure that you know that there is not an alteration in consciousness with dementia. It is irreversible. So unlike delirium, which can be reversible, dementia cannot be reversed, and its progression causes memory impairment and a loss of intellectual abilities severe enough to interfere with daily life. Some degenerative dementia conditions are Alzheimer's, dementia with Lewy bodies, Parkinson disease dementia, frontotemporal lobe dementia, and other less common. If you remember, it was 80% of all dementias are from Alzheimer's. That's your statistic. That's not a random Wendy statistic. That is a true statistic out of your mental health book. Incidence and prevalence of dementia. It is the most disabling and burdensome of chronic conditions in the older adult. Frightening implications face the client and the family, and the societal costs are related. There's societal cost related to the disease. So it affects everyone basically, right? It affects the patient, it affects the caregivers, it affects the family, it affects us taking care of them. Very hard to watch. And remember, your family is one of the most vital places to get information about the patient and what they were like before, especially going back to delirium. If you have someone that's older adult that's acting much differently, especially if you're working in medical floor and the family is saying they never do this, this is not normal, something's different, listen to them. You know, really listen to them and try to implement stuff based on that, and advocate for them, because a lot of times our docs will say, well, yeah, that's normal though, or whatever they say. Make sure that we're advocating for our patients and changes that family or we are seeing. Alzheimer's disease is the third most common form of dementia. It is the third most expensive medical condition, all medical conditions. Types include early onset and late onset. Late onset is the most common, developing after 60 years of age. But think of what 60 is today. I mean, 60 is not an old age anymore the way that it used to be. Like when young old was determined to be 65. I mean, we still, at 65, people are doing a ton of stuff. So, 60 years would be quite young to start losing in the memory and, start having this form of dementia. So potential risk for Alzheimer's includes include vascular risk factors, midlife obesity, dyslipidemia, hypertension, cigarette smoking, sleep apnea, diabetes, and cerebral vascular lesions. So that could be something from a TIA originally, but they will find all these lesions in the brain of patients with Alzheimer's after they've passed. Protective roles and psychosocial factors, so behaviors that possibly cause protective abilities include higher education, regular exercise, healthy diet, intellectually challenging leisure activities, and active social integrated lifestyle. So a lot of these things we can make an effort to do on our own, right? All of you are working towards higher education, getting regular exercise. And that doesn't have to necessarily mean getting on a treadmill or a elliptical for 60 minutes every day. That could mean taking a brisk 30-minute walk 3 to 4 times a day or 3 to 4 times a week, and you're getting regular exercise. Eating a healthy diet, so having those things like pizza or fried chicken or things that people really enjoy on occasion versus, every single day, but trying to always include those healthy grains and healthy leafy vegetables that we need. And then challenging leisure activities that cause the brain to really have to think. Think of something that you have a hard time with. For me, that would be puzzles. I have the hardest time with puzzles. So I would really have to intellectually think when I'm doing a puzzle. So that would be a good thing for me to try to implement in my own life, something that's challenging for me. And then active socially integrated lifestyle. So we want to, having close people in our lives, doing things socially with others and having those connections are all things that have shown to be protective factors against Alzheimer's. So your 3 stages are preclinical, mid-cognitive impairment, and dementia as a result of Alzheimer's. Remember, in mental health, when I covered this, we did the early, middle, late stages. The goal is to provide standards for research and practice that further advancement the field for early detection and education. Treatment is ongoing monitoring of disease progression, regular health maintenance, and health promotion. Assessment 6 months after diagnosis and any time a change in behavior occurs. Administration of cholinesterase inhibitors and residency in an Alzheimer's care unit. Common care concerns, communication. So remember, the patient's communication is going to deteriorate. Behavioral concerns, activities of daily living, and wandering. Because we are going to have to help our patients with Alzheimer's, especially when it's advanced and, in activities of daily living. And we have to watch safety, then that would include the wandering. Progressively lowered stress threshold model. So, is the first model used to plan and care for those with dementia, and this care decreases the stressors and provides a safe, predictable environment. Be sure to read up on that in your book. Need-driven dementia compromised behavior model is the model provides a framework for studying and understanding behavioral symptoms of dementia. Interventions are performed to minimize behaviors or actions. And so then our implications for the Jerry nurse, we want to make sure we are assessing. Behavioral changes occur with distressing conditions such as constipation or UTIs. Behavioral symptoms include fear, discomfort, unfamiliar sounds. Comprehensive assessment and the use of medications are the treatment of choice. Make sure you remember that. Bathing can be perceived as an attack by the client, so we got to be careful with that. Caregivers, stress of the caregiver caused by, read through those. The caregiver plays the role of magician, detective, carpenter, and gesture, so you just want to make sure that you are being an effective caregiver. Sorry I rushed through that last part, but I only got 10 seconds left. Make sure you go over that in that portion in your book, and I will be in touch with you guys via email.